Oh, we're live. Good.
We're start. Good afternoon. Welcome to the CAMS COVID webinar. My name is Dr. Turlough Mills, child psychiatrist at Little Woodhouse Hall, and this is my colleague.
I am Emma Sutcliffe, the team manager at Little Woodhouse Hall.
And just before starting, we've got a few housekeeping statements that I've been reminded of. The webinar is a live event, therefore your camera and microphone will not be turned on unless you're a speaker. The webinar will be recorded and uploaded on the Royal College website. Please use the chat function to ask questions, and I believe you can vote for the questions you want answered the most, and use the chat box to let us know if you'd like any specific topics covered in future webinars. So both Emma and I work at Little Woodhouse Hall, and I was asked by the QNIC team a couple of weeks ago whether I'd like to present a webinar on how to attend to morale during this difficult time of COVID. I'd actually just come out of isolation myself and wrote back saying I'd be delighted as soon as I'd worked out the answer for myself. And the QNIC team wrote back and said they were being serious about it and would I please do it. So I thought very briefly about going back into isolation, having never done a webinar before, but agreed as long as I could do the talk with Emma, who's been on the ground here at Little Woodhouse Hall pretty much ever since the lockdown was announced and started, and who's really been responsible for leading our unit through all the changes that we've had to make. So we really don't have answers to the question, and I think it's important to start by saying that although there are similarities between units, there are also differences. We're an 8-bedded unit in an old building. We serve the population of West Yorkshire. It's quite a unique feel of a building. It feels homely. We don't have much access to outside space that can be unsupervised, and I think importantly we currently don't have any patients who are infected with COVID, and that is that's affecting and shaping our experience of the crisis. But for those of you who have joined, I think it was our hope and the hope of the QNIC team that hearing about our experience and how we have managed it might be interesting. I hope it helps with sharing some ideas, and I hope it can foster a sense of solidarity, which is really what QNIC is all about. One of the things that we found really helpful over the last 4 weeks is talking to other providers, being linked into provider networks and provider Teams calls, and just I think hearing that other people are experiencing what you are experiencing can be helpful. So thank you to all those who wrote in with questions. Thanks to all those who've contacted us. Hello to the team out in Qatar, and we're really looking forward to the Q&A at the end. We're really interested in what other people are doing as well. We've in very broad brushstrokes, I think, divided up what we were going to talk about into stages. As I said at the start, just before lockdown, I went into self-isolation myself, and with extreme rapidity, the service and Emma and the trust and all of your services and all of your trusts had to respond very quickly to dramatic changes in public health guidance, and I think over a very short period of time we saw a huge change in the way that we could deliver a service. So Emma, I think you were there at that start, and I know one of the anxieties was around how much personnel there would be. How many psychiatrists did you have in the unit by the end of the first week?
None.
None. No, that's right. And other staff as well?
Probably 3 or 4 people went off with symptoms. So we sort of felt depleted, but then it also felt like everybody put in extra to cover those gaps. Mm-hmm. So while it was a time where we all felt a bit, what did you say, discombobulated because everything changed so rapidly, it didn't feel as though the unit was particularly understaffed. It was just maybe a bit differently staffed, with people out on the ward who weren't usually out on the ward, people seen doing different things. That was a bit odd. Mm-hmm.
And I guess my understanding is at that point there was a real worry that as the weeks went on, we might be down to 40% reduction, or down to half of our workforce, and that hasn't happened actually here for us. But at the time, it felt like it was a real possibility.
Well, yes, 40%. I don't know where the 40% figure came from, but that was what was being said, that over time there was an anticipation that it would be 40% of staff down, which on paper does sound quite worrying, but we haven't seen that. But that doesn't mean we won't.
And there were early contingency plans, and they exist now, don't there? So
yes, yeah, there were. So our community teams have been stripped back really to the bare minimum of looking after people who really need a lot of support in the community, and then most people have just been redeployed to ourselves, outreach, our sort of community team, and the crisis team.
Okay. We also had to make, I suppose, school stopped pretty quickly. Suddenly the schooling was withdrawn. Things like external therapy, visits, leave.
That did, but that changed over time and was sort of almost a gradual grinding to a halt of things happening. And we were, I don't know, in the initial days thinking, well, should people be coming in? Shouldn't they be coming in? And that was following bits of advice from here and there, and without really seeing the bigger picture of what was going on, because we were concentrating on what was going on here. So things changed, and then they changed daily, or they changed several times a day, and became more stringent, really, the visiting, the social distancing, and all those things, which just completely unheard of. So we're all trying to get our heads around this crazy thing that was happening, with a bit of a lack of staff, but also just getting on with things in this odd little bubble that we've created, which is Little Woodhouse Hall.
So we and again, I think just the speed of decision making was that the service and the trust had to digest and then carry out rapidly changing guidance over a short period of time. So by the end of 2 weeks, we have arrived at what our current policy is. So young people are not accessing leave unless it is extended leave to try and facilitate discharge. So those young people for whom discharge is thought to be a high chance of success and the most appropriate stage of their planning, they can access a 2-week period of supported leave with the intent to be discharged at the end. We don't have any family visiting apart from in exceptional circumstances. We don't have family visiting to accompany young people on exercise or walks or short periods off the unit. I think it's probably taken some time for us to try and facilitate those for young people anyway. Social distancing on the unit, I think we've arrived at that by considering the young people as a family group, and then we are external visitors, really.
After trying various things, I mean, this building does not lend itself well to social distancing. I mean, this was
we are not social distancing.
But you know, we've got narrow corridors, we pass each other, and we tried to get the young people to consider social distancing, but they find it hard. I don't think, I'm not sure, partly that they get it because they are in this bubble, although I think they might be cross with me for saying that, because, you know, but yeah, eventually we came to the conclusion that we would put our PPE kit on and we would be the unclean and they could be almost sterile, as sterile as we can make them.
And PPE arrived at some point along this journey, and then
I don't feel that we have had a problem with PPE.
As in supply, we have had.
As in supply, there's absolutely enough to go round. We sort of wobbled through the instructions of when we should be wearing it and what have you for a bit, but I think we're okay with that now.
We are, and I guess just as I said at the start, our experience of using PPE is of course shaped by us not having any patients who have COVID. But we did have. We had a patient who went into, well, we had 2 who went home, so that sorted that out, and then 1 young person who was it would be too difficult to send them home, who went into, fortunately, that area that we had. So we isolated.
So we were quickly into PPE when we weren't wearing PPE initially. When we were down in the isolation area, it sort of gave us a taster of what's to come, really.
Okay. Any other thoughts on that initial that 2-week period?
This sounds ridiculous, but it feels like a long time ago now. Discombobulated is a really, really good way of describing it. I think personally I felt very out of kilter then, and nobody was really sure what was going on, and there was so much advice coming and things were changing so often. I mean, I have to say, I think that the team here really stepped up to the plate immediately. It was like, you know, there's this huge crisis and everybody needs to be involved and we all need to do our bit, and they were amazing. Everybody did their extra bits because we were a bit short-staffed, and short-staffed suddenly, you know, people couldn't cover night shifts and couldn't do bits and bats. And then I think the young people have been pretty amazing as well, to say that their world has tipped on its head as well. And we were all in that together, really. I can't remember how it felt. It kind of feels okay now. It doesn't feel like the new normal, but things feel calm, if I can use that word.
Well, I mean, I guess this, in my mind, I've designated this time we're in currently as the sort of middle stage, that we have adapted to something and we are now in something. And we are not quite sure what is yet to come, but this is what we have currently, and we have done some things, I think, to try and mitigate the challenge that we have. We have a group of young people with who require inpatient admission, who have no visits from their family. They can use their own devices to keep up with using video technology or other things. As I said before, we don't have an ability to have unsupervised access to the outside, even despite this wonderful weather we've had, but we do have grounds that we are trying to promote as much time in the grounds as possible. We have no school, and I think again the challenge of trying to take a timetable with core components missing, and to make it meaningful has been a challenge, and one thing that you've done is take therapists into the numbers.
Yeah, so our therapists have offered to be in the numbers, and they've been very great in producing a programme which ideally for us, we would split our young people, 8 young people, into 2 teams and run a therapeutic activity alongside a creative activity, one in the morning, one in the afternoon, and mirror the two. And I think that's taken time to put together, and it's a lot of time to fill for young people. You know, everybody's feeling that with their children at home and what have you. So we are trying to fill their time with things that are meaningful, and that's an ongoing thing. I think it's great that some therapists are managing to work really well from home. So really good family therapy is happening from home. The 2 who have put the programme together have worked really hard to do that, and again we had to think about social distancing and whether we couldn't, should, how helpful it is to have therapeutic group behind a mask, or, you know, whether facilitators behind a mask and things. So I think it's been odd, but everybody's sort of, there's no real, nothing to compare it to, is there? You can't say, well, last time we did this, because there just wasn't a last time. So it feels like we are doing our best and hopefully managing okay in extreme circumstances.
Technology has been challenging, hasn't it?
I think for me, that's what I've been really anxious about, because I'm not a technological minded person at all. I don't like it, I'd rather avoid it, but it's had its ups and downs, let's say.
I think for trying to help the parents of our young people remain connected and remain involved in care, and maybe the amount of support that a parent derives just from coming onto the unit and having some a talk with nursing staff, or a chat or a catch up, or just seeing things, and suddenly when all of that contact is stripped away, I think those who are caring for young people who are at home and not able to see them or see staff find that, as it would be, hugely challenging. And I'm not sure that there is a perfect technological solution for it. We're using Microsoft Teams for our CPAs and for some remote therapies contact, and I think again, parents of young people are sort of keen to embrace that technology and use it, but it's obviously never as good as face-to-face contacts. We did have a question come in about, were psychiatrists working in units? Yes, of course they are. I am in. I know in communities, teams are adapting to doing much more remote work and work based from home. But it feels to me that at this time, given the challenge, and I think it's a hard thing to have lots of worries about the effect of a virus, or to be knowing that one is leaving one's children at home or in an altered school environment to come into work, and the degree of support we can give each other as a team is important. And again, we can do some attendance at meetings through video conferencing, but actually having support for each other, and being available for additional supervision and discussion is, I think, really important. In terms of extended leave and community support, I know, again, I think it's so difficult for young people and their families to feel that the admission is progressing in a sane way towards where they want it to be. And obviously for all our admissions, there is a clear endpoint of being discharged and going home. And we understand that home isn't just a house with your parents and your family in it. It is your social contacts and your school and your aspirations and your ideas and your friends and all of those things. And suddenly that is missing. And I think that makes trying to think about moving towards discharge hard for families and hard for their parents.
I think, just thinking about it now, that also has been quite hard for the recently discharged, who, you know, had got to a point where they could be discharged, and then very quickly the life that they'd been discharged into, with school, with seeing their friends, with all those things, was gone. Just, you know, gone. And I can imagine that would be a struggle as well, and a great shame, but it is what it is. So
it is, and I think for those who want to go home and who want to try being supported at home, we've certainly had some very good experiences of community teams putting in very robust packages to help children move from the inpatient environment to home, and this is recently within the last few weeks. But it is hard, and I think for young people who maybe are prone to overzealous introspection and self-critique, then it is possible, I suppose, to feel that a hampered ability to move towards discharge is another failing. So I think we've tried to have our young people feel looked after and cared for and safe, and that be the priority for now, whilst we still move towards something that we're not quite sure where we're going towards.
Or how long it's going to last.
Or how long it's going to last.
We're in this for, really.
And I think it feels to me that we are in a stage. We've made adaptations. Our staffing shortages are in no way as severe as we had worried. That may change. We are not managing actively unwell patients with COVID. I think we've created an environment that feels safe and protected for young people, but knowing where we go to, where we go towards is probably trickier for everybody. And I think one of the things that we've talked about and worried about is that now, 4 weeks on, I think in a way our young people are lucky. They're being looked after, they're being cared for. But for children at home, like Emma said, someone who maybe had got to a point of being able to go home and then home has suddenly changed, that's very difficult. For children being at home in environments that are not stable or are not supportive, without any of the normal access to getting out, having a break, the therapeutic effect of school, I think we are very worried about what the impact would be for them. And I suppose I would anticipate seeing an increase in crisis presentation if indeed that's not already happening. We did talk before about it's hard for the young people who are in our care, carrying on with all these big changes, and you were saying that they're very, very acutely conscious of who shift pattern changes and what the meaning of that might be. And
I think in the beginning, I was going to say they seem fairly well sort of adapted to this new normal now, but in the beginning, when people who had been doing night shifts were suddenly pulled on to doing day shifts, I was really surprised that they recognised it and were like, well, you don't work on a day shift, you work on a night shift. And they knew that there would be other people coming in who had been redeployed maybe, and they were anxious about it. And so they were anxious and we were anxious. And I wonder how somebody who'd come onto the unit might describe the feeling of how everything was then. It doesn't feel like that now. It feels like we have settled into what is our new normal. I mean, obviously, we maybe now have the problem of teenagers being bored, which is difficult. But it feels like we're managing.
It does feel like we're managing. I suppose staff still are coming to work with fears and worries and anxieties.
Absolutely, I know they are, yeah.
Anxiety about being exposed to things, just being out in public, about what might be at work, worries about own family, worries about leaving their children behind. And I think the work is disturbing in and of itself, and is emotionally turbulent, and providing containment can, I think, be harder when one's own resources are in some way depleted by a global pandemic, and a sense of free-floating anxiety and a wonder about where things might end up. And when we've talked to when we've talked to the team, they've identified the usual things that are helpful: accessing supervision, accessing group supervision. We picked up an idea from Oxford a couple of years ago about holding a daily community meeting with all staff, and we've continued that for the last 2 years. First thing in the morning as a time to touch base with each other and work out what we're doing and iron out any dynamic challenges. We've added in an extra group on a Tuesday for staff and for young people together. We've added in extra time after handover to have supervision around maybe particular challenges that day, or particular things that nursing team are concerned around. We've identified an increased need for formulation and are doing that more as well, and attempting to formulate problems as they come up. And staff have all said, particularly those who've been working extra and pulling on their own resources, that remembering to have leave and remembering to relax on your leave is really important. I've drawn on additional support. The QNIC discussion group, I think, has been really helpful. It is just helpful knowing that other people are doing similar things and facing similar problems. Particularly in the early stage, I sent emails to colleagues in different units, and we're part of a local NHS England providers group on MS Teams. That is extremely helpful, just as a way to sort of touch base with what other people are doing. And although we are different, we have similarities, and we are often facing the same sorts of challenges. The Royal College has published some really good articles, I think, on resilience, and we have an additional slide. Aaron, is it up? I think we're coming to the end of what we're going to say, but a slide on the Knowledge Hub about accessing additional support around COVID, linked through QNIC and QNCC. So I think we're coming up to the end of our free-form discussion, and would then be open to any questions, and we can sort of discuss those and implications of those. Emma, have you got anything else you wanted to say?
I don't think so. I think that's been quite helpful just to sit and sort of think about how the journey has been so far, and how things have changed from, you know, the initial lockdown, if you like, and how we've managed it into where we are now, where, like I say, it feels manageable, if not comfortable. It feels that we are okay with it.
Yeah, and the nature of time has changed, hasn't it? It has only been a month, but it feels much longer, and just how exhausting it is to respond so quickly to so many changes. But I think, you know, I think we've been well supported by our trust and by their links with other providers to get to this place, really. Okay, thank you very much. That's the end of our talking bit. And I think we now it's got a question from Dominic around how we are helping safeguard vulnerable children in possibly abusive homes. How do we get that support right, and who have we taken advice from? This, I guess, this is not an issue for us right now, but it may become so. And I think linked back to what we were saying, that children who may be coping in adverse situations, who find themselves in the same situation but without any of the usual modes of support, are at increased risk. What an inpatient unit might do, I suppose, other than what they would do normally, is to have very close relationships with social care, to start safeguarding procedures, to be very conscious of the impact of discharge for a patient who was liable for discharge. And I think we've had a experience recently of really close working with social care, and also, I suppose, understanding that things have changed, and we wouldn't be rushing to discharge a child into a dangerous environment if there were not sort of adequate safeguards with that. So I think it's a really challenging point and an area. We've not had an immediate experience of that right now.
I think children like that may be on the radar of community teams rather than us, unless they're already here.
Yeah.
You know, we're lucky enough to have our social worker who's got some really good links with other social work teams, and it has felt that we've worked really well with social work teams. Do you feel that?
It does feel like that recently.
Yeah. Feels like a bonus, actually.
Okay. We have a question from Merlin Park CAMS, just saying that Merlin Park are not accepting visitors or families to the unit in line with protocol, have been utilising the social media platforms. We are now 6 weeks in, young people are homesick and upset over loss of physical contact. And what have other units experienced, and has anyone implemented a strategised visitation policy or procedure? So I don't know what the answer is to that. I think different units have different visiting policies. I'm sorry, I don't know if Merlin Park is for young children or for adolescents. Our adolescents are not particularly experiencing homesickness, I think.
I'm not sure. I think just recently a couple, maybe more, want to see their parents, and especially, you know, we've had one young person who's had a relative die whilst they've been in here. That has been quite hard to manage, and I think what is also a little bit difficult is that in some extenuating circumstances visitors are coming here, and I think our young people have been really amazing at accepting that is okay for a couple of people, but it doesn't apply to them. So I think that does feel like something that's going to become more acute as time goes on.
And I think that's, just looking at that question, will go on the Knowledge Hub for further responses. That's a really good place we could share experience with. What are other units doing in regard to PPE and NG feeding? Are they treating NG feeding as an aerosol generating procedure, particularly if needed to be done under restraint? What are we doing?
If under restraint, yes. This is one of those things that changed and then changed and then changed again. I think we are at the moment considering it not aerosol generating unless we're doing it under restraint.
Okay.
So, which we're obviously trying not to do, but if we were doing it under restraint, yeah, before PPE, and we've got all the gear for that ready. All the
special visors. Okay. Question about whether other CAMS inpatient units have closed to new admissions. We haven't. I wondered about whether other units have policies around routine swabbing or testing of new patients, particularly from transfers from acute wards, acute medical wards. I'm not aware that there is any linked up policy around that. We have
more about isolation. I mean, I suppose other units won't have the ability to isolate that we have, but we did think about when having new admissions.
Mm-hmm.
We've had 2, I think, whether they should spend a period of time in isolation before they came onto the unit. They didn't. Mm-hmm. One was swabbed and one wasn't.
I think for our unit, we are very much going along testing in response to symptoms rather than asymptomatic testing. Question from Louisa Cams ST4 about whether our increased use of video might be positive changes, and whether other teams are tracking changes being made, or what outcome measures are people using. I don't know the answer to that. I suspect the communities are using video for therapy more than we are, but that'd be a really interesting question for QNCC or the Knowledge Hub. Are we using PPE all the time? If so, what are we using? Do your staff wear masks all the time? We have designated, our unit is over 3 floors. The middle floor has the young person's bedrooms, there's relaxation room, lounges and other things. The top floor has some more therapy spaces and some office spaces, and the bottom floor has the dining room and some other large rooms. So we've designated the middle floor as, because our corridors are so narrow, that we all use PPE all the time on the middle floor, because we cannot guarantee social distancing. And if we were in that area without it and turn the corner, you might bump into someone.
The young people know where they're at then, don't they? Everybody's wearing PPE whilst you're on that floor. That's what they become familiar with. If we hold larger meetings, say a community meeting, we're doing that now downstairs in a very large room, where young people can sit on one side and the professionals can sit not quite on the other side, but 2 meters apart, and then we can remove our masks. So it's a slightly less alien experience for them. A really interesting question about how COVID is affecting children and adolescents in terms of their behaviour and their mood, and what are the aspects that differ from the problems being caused in adults. I suppose we know the answer to that, other than all the things that we've said. We only have a population that is unique to our population. I think they feel looked after. They bond well as a group. I think they feel, maybe unbeknownst to them, rather insulated from what's going on, or rather protected from it. Certainly within communities, I think children are regressing and are struggling in all sorts of different ways, and it might be in some ways an easier, if you need to be in an inpatient unit, an easier place to be surrounded by adults who are looking after you and who are working shifts and who are managing their anxieties, than maybe to be at home with parents who are really worried and worry about all sorts of things. So our group appear to be resilient and to be working well, really. But obviously every unit is different, every child is different, and all these situations are different too. A service asking about is they've not stopped weekend leave, ground leave with family, or visits from a parent. Looks like many units have stopped this. Are there other units allowing this much leave? I don't know. I'd be really interested.
I'd be really interested.
As well, yeah. Because going forward, those are the kind of things that probably will need to be addressed, won't they?
Yeah, and I think as a provider across Yorkshire, I think we are wondering whether we should be facilitating visits from a parent on the grounds. That can be social distanced. Could parents join daily walks? That could be social distanced. We've had some helpful challenge from the advocate about why we are not responding to this. So again, bearing in mind how quickly we've gone from total countrywide lockdown to here, I think it's reasonable that trusts and services are cautiously feeling their way, but it doesn't it doesn't feel right to me that this is the status quo as we go on forward into the future. I think children need to see their parents and parents need to see their children.
It feels like we'll be in a very, very stuck situation if, when we start to emerge from this, and people haven't seen their parents for weeks and weeks.
Good question about education. What are the reasons for education not to be offered in Tier 4 units during lockdown? Their education centre is open and staffed. Well, aren't you lucky? That's great. And hopefully, again, this may change for us. I suppose.
Sure about the reasons for it. There's been some contact with education, but definitely we are not open.
Just a very helpful response about testing new admissions, saying that one paediatric trust has not found evidence to support screening of asymptomatic teens. Another ST prior offering a positive experience of an inpatient unit has got used to ward round CPAs running virtually due to the consultant needing to shield at home. Another comment about a rota of medics on site and those working from home. I should say that the one really helpful, really positive aspect of redeployment is we've had junior doctors coming in to support each other in the unit, and they've got some really good experience. They've been able to have an experience of inpatient unit that they wouldn't. I think
they're getting some really good experience as well.
That they wouldn't otherwise have had in their placements. That their other placements are obviously restricted, so that's been great for them and really good for us. Question about CAMS eating disorder patients being badly affected. I think it's really interesting. We've not seen that. Again, maybe that could go on the Knowledge Hub. We're not doing handovers virtually. We do NG feed our patients.
Partly we are.
Oh, I'm sorry, we are partly. Yeah.
So some people who are working from home, like our family therapist and one of our psychologists and one of our junior doctors, up to a point, we were putting a phone on the table and they were listening to it all. But it meant they could participate. So our communications platforms aren't the best, but we are trying to keep as many people.
Yeah, and I think from this week, I mean, we have, particularly our social worker, we've had some great support from Alex in our trust about setting up Microsoft Teams, and I think we're now entering the exciting era of Microsoft Teams really helpfully supporting our handovers and our reviews. So we've gone from sort of struggling, I think, last week to feeling that the technology is there and supporting groups of clinicians and professionals and young people and their parents to come together for these planning meetings.
We're using various methods, aren't we, really? It's a bit cobbled together sometimes, but it's working. People are involved.
We've got a question from Yasser. Hi Yasser, just wonders how we're managing young people who may develop respiratory symptoms or symptoms suggestive of probable COVID on the ward. Do we use a specific tool to triage them prior to seeking further help? So while I was in isolation because my partner was ill, we did have some young people with symptoms. One with fever and cough and am I right in that? And I don't know if we had a tool. We arranged for isolation for that young person. We also arranged for other young people who could go home to go home for a period of leave.
I think actually, had it come to it, so we had the two who went home and then one person who was able to be isolated on a separate bit of the unit, which we're lucky enough to have. She ended up being tested. She was almost out of isolation anyway by the time that came round. I think if her symptoms had worsened, then we just followed government advice, call 111.
Yeah, so we've not had anybody be physically sick with us.
No.
Question from Alan. Hi Alan, just about wondering if we reduced bed capacity at all. We have not.
We are only 8.
We are only 8 anyway.
Others might have,
yeah, and I suppose what we have done that is linked to that, as everyone is finding, it's very, very difficult to plan for discharge without leave. It's very difficult for young people to test their toes out in the water of being out in the world and managing things when they can't have leave and the world is all very strange anyway. But we are for those for whom it is appropriate, they are having a 2-week period or up to 2 weeks of leave beforehand to see if leave can be managed to go to discharge. I think we're all holding our breath a little bit to see what's around the corner and to see what happens with crisis admissions. So we can let you know when we get there.
That just going on to the, how do you manage to sort of swabbing young people? So we're not swabbing. So we actually, when we had that young person who was isolated on the unit, she was swabbed, but at the same time IPC came down to swab her. We had a new admission, but the policy was not to. So we're guided a bit by other policies, but the IPC policy was not to swab her. Yeah. She wasn't symptomatic, so not to automatically do that.
And that's where we still are. So young people who are symptomatic, we can get testing for them. We all obviously welcome the government's announcement of testing for all NHS workers who need it. Should any of us get sick again, that'd be very helpful. And yes, I think that we will continue as that really. Any delayed discharges because of the current situation? No, we haven't. But I could well imagine a situation where that might happen.
I think we've been quite lucky in that NHS England have tolerated people going home for, I mean, obviously times are different, but they're going home for a couple of weeks where that's usually not acceptable. So yeah, we haven't yet.
Will there be an opportunity to look over nursing records and see whether incidents increased or decreased in frequency since lockdown begun? It's always really interesting, these analyses. Incidents are quite carefully audited, and I think we would be able to see a pattern. I want to say I don't think that has happened, but I think we will wait and see until we can. And also, we are where we are now, but who knows what's around the corner really. Something about ADOS. I'm afraid we don't do ASD assessments. And then just the last question of it is: the therapy team still offering therapies, or are they in ward numbers? They are still offering therapies, and they have put on some more groups, therapeutic groups in addition. So young people are accessing family therapy, individual psychology, creative therapies, additional sort of supportive therapeutic activity groups, as well as one-to-one staff seeing me and my other junior doctor colleagues. So it feels that we've worked towards providing a fairly robust and fairly lively therapy programs for them.
I think what our therapy team have offered to do is to not go home and work from home, which I guess they could have had the opportunity to do, work remotely and do that. They have said that they will come in and do the groups face-to-face, facilitate the groups face-to-face, because it's so much better for the young people. And then they have said, if other members of the nursing team are sick, they are around to help out with the things they know how to do. So they could be absorbed into ward numbers, but generally they are not.
Okay, and I think that is the last of our questions. Thank you very much for everyone who's participated. We found it, again, having never done a webinar before, I think it's been really useful just to, Emma said, just going over what the experience has been. I really hope people have found it interesting. These are huge challenges that we are managing, and well done everybody, and thank you very much to the QNIC team for arranging it, and they're putting on more seminars. I'm looking at Aaron here and he's nodding, so we should have lots of interesting things to engage in, and it is really what QNIC does best, is to support each other and to share ideas and to share good practice. So I hope those of you can get to enjoy a lovely sunny weekend, and I think we need to remember just to look after ourselves, get rest, and then come back into work feeling all reinvigorated. Okay, thank you very much indeed.
Thank you. Take care, everyone.
Goodbye.